an associate professor in the Department of Cardiology at U.N.M.I.C.R.C Institute of Cardiology and Research Center. I'll be discussing today on a very important topic which is transcatheter aortic valve implantation or transcatheter aortic valve replacement. It's TAVI or TAVR. Now this is a procedure which is very enchanting, which is new and something that has now exceeded a surgical aortic valve replacement, at least in the Western countries, particularly the United States and most of the European countries. Procedure wise, it's much simpler as compared to surgical AVR, although some of the procedural complication rates may be higher as compared to surgical AVR, but it offers significant advantages over surgical AVR in terms of mortality and morbidity. Now the problem of aortic stenosis is it's a very big problem, predominantly because of the increasing life expectancy. With the increase in life expectancies up to 80 years of age, we expect that the proportion of patients with severe aortic stenosis is going to increase considerably. We know that aortic stenosis, once it becomes symptomatic, it's a very problematic disease. So average survival after the onset of angina is around 5 years, after the onset of syncope is around 3 years, and once the patient starts developing heart failure symptoms, the average survival is only expected to be around 2 years. So for most of these patients, some form of treatment is required in the form of valve replacement. You either do a surgical valve replacement or you do it as a transcatheter aortic valve replacement. Now aortic stenosis severity, although this slide is very congested, we know that severe aortic stenosis is when your aortic valve area is less than 1, your mean gradient is more than 40 and the velocity is more than 4. Now stage C1 is asymptomatic severe AS with normal LV function, and stage C2 is asymptomatic patient with depressed LV function. D1 is basically severe symptomatic aortic stenosis with normal LV function. Stage D2 is low flow low gradient AS, that is when your routine echocardiography gives you your gradient of less than 40, valve area of less than 1 and your velocity of less than 4 meter per second. But when you do a dose-bitumen stress echo, also you have LV dysfunction, but when you do a dose-bitumen stress echo, you find that all your parameters change. Your gradient increases to more than 40, velocity goes above 4 meter per second, and your aortic valve area remains pretty much the same, that's less than 1 centimeter square. And stage D3 is paradoxical low flow low gradient AS with a normal LV function, basically occurs in patients who have an afterload mismatch. Now very important, when you are subjecting a patient to an aortic valve replacement either surgically or transcatheter, you need to confirm the severity of AS. If the patient has a normal LV function and your gradients are high, your velocity is high, then you are very much sure that this is a symptomatic severe AS. Otherwise, in patients who have a velocity of less than 4, your gradient is less than 40, you may need to subject these patients to a dose-bitumen stress echo, right? If dose-bitumen stress echo in these patients shows that your aortic valve area remains less than 1 but your gradient increases above 40, then that means that it is a low flow low gradient AS with a depressed LV function, that is stage D2. But if in a patient baseline echocardiogram shows that your aortic valve area is less than 1 and your gradient is less than 40, but you subject them to dose-bitumen stress and their gradient does not change significantly and your valve area goes above 1, then that means it's a pseudo-severe aortic stenosis and they should not be subjected to valvular intervention. For paradoxical low flow low gradient severe aortic stenosis, the treatment of choice still remains surgical AVR, that is the stage D3 patients who have an afterload mismatch, right? So left ventricular dysfunction in aortic stenosis could be multifactorial. It primarily is because of afterload mismatch, because of the high gradient. Secondly, it could be because of an inherent cardiac dysfunction, the contractile dysfunction. This is a problematic subgroup, especially when your EF is less than 20 or 25% and your gradient is low. Then you are going to subject these patients, as I already previously mentioned, to a dose-bitumen stress, and you see whether it is a pseudo-severe aortic stenosis or it is a true aortic stenosis, which comes into the D2 category, also known as the low flow low gradient aortic stenosis with reduced LV function. Right. The first conception of a transcatheter aortic valve implantation was by Anderson in 1993, where he showed that a valve can be sutured onto a stent in an animal model, but the major problem was it caused coronary artery obstruction. The first human implantation was done by Dr. Cribier in 2002 in France, where he implanted a bovine pericardial valve implanted on which was crimped on a long balloon. As we can see over here, we have a bovine pericardial valve which was mounted and crimped over a balloon, and it was deployed across the aortic valve with an excellent result. Following this, we have several milestones in the field of TAVR. The first TAVR being done in 2002, and in 2005 TAVR basically is done in more number of patients. 2007 it receives a CE mark approval. 2010 we have the partner trial. 2011 partner A trial in high risk subgroups. 2012 FDA approval in high risk patients. 2014 we have the self-expanding valves. Partner 2 trial in intermediate risk patients in 2016. 2017 we have the Tavi-Cce trial, and subsequently the guidelines have evolved over the course of these years to accommodate the scope of transcatheter aortic valve replacement in patients with severe aortic stenosis. So if you look at the indications for aortic valve replacement in patients with aortic stenosis, whether it be transcatheter or it be surgical, so AVR is indicated in patients who are symptomatic severe AS, that is class D1, in patients who are class C2, that is asymptomatic patients with LV dysfunction and severe aortic stenosis, or class D2 and class D3, that is class D2 is low flow low gradient severe AS with reduced LV function, and class D3 is paradoxical low flow low gradient severe AS. Also, surgical AVR may be indicated in patients undergoing some other form of cardiac surgery like CABG and mitral valve replacement if these patients are found to have severe aortic stenosis incidentally. So now deciding whether you are going to go for a surgical or you are going to go for a transcatheter option, patient and the prosthesis selection are very important. Most important thing is we need to have a heart team. The heart team should consist of a cardiologist, a cardiac surgeon, a cardiac radiologist and a cardiac anesthetist. Patient selection criteria which will be very important in determining the eligibility for a transcatheter approach would be the STS score, the Euro score and some other risk factors in the frailty indices which are not covered by some of these risk scores. Now the traditional criteria is TAVR should only be done in patients where your life expectancy is to be more than 1 year and a chance of survival with benefit of more than 25% at 2 years, and if your anatomy is favorable for a transcatheter aortic valve replacement. So after you've done your preliminary assessment and established that the patient falls into one of the categories for surgical or transcatheter AVR, either has severe aortic stenosis or asymptomatic severe AS with LV dysfunction or very severe aortic stenosis which is asymptomatic, or in class D2 or D3, we are going to do a risk assessment. The risk assessment basically comprises of calculation of the STS score and the Euro risk scores. STS score of more than 8 and a Euro score of more than 15 are considered very high risk for surgical AVR, and they are preferably opted for transcatheter aortic valve replacement. Other important factors which are not covered in some of the traditional risk scores include a porcelain aorta, very calcific aorta, prior mediastinal irradiation, very severe left ventricular dysfunction, very low FEV1 or a very poor pulmonary reserve, those who have chronic kidney disease, chronic liver disease, those who have cerebral dysfunction and those who are very frail. So this is one of the risk scores, that is the STS risk score, right, which takes into account what is the procedure, that's the aortic valve replacement, what is the age, does the patient have lung disease, immunocompromised status, risk factors for endocarditis, does the patient have an inserted IABP, does the patient have a history of prior MI, what is the creatinine level. So there are several variables which are included in all of these risk scores, both of them, STS as well as the Euro risk score, and there are pre-made calculators available which help you calculate the STS and the Euro risk score. I won't go into details of how you are going to calculate these because it's pretty much easy and is available on all online platforms. I'll discuss what are suitable patients for transcatheter. So basically transcatheter is for those subgroup of patients who are considered to be very high risk for surgical AVR. So somebody who is less than 50 years of age should not be subjected to a transcatheter approach unless there are some very strong indications. So this is mostly for elderly patients who have a very high risk for surgical AVR. So somebody who has a favorable anatomy for a TAVR is a calcific sclerodegenerative aortic valve. There should not be very significant aortic regurgitation. Very important is that your coronary height should be at least 10 millimeters. So your coronary artery location should be at least 10 to 12 millimeters from your sinus. Femoral artery anatomy should be good. It should not be very tortuous, should not be very calcific and diseased. Data on rheumatic aortic stenosis is limited. Most of the data comes from degenerative aortic stenosis. So elderly patient, tricuspid valve, very calcific valve, high risk for surgical AVR, good femoral artery anatomy, these are all suitable criteria for a TAVI. Relative contraindications are a non-calcified valve, a bicuspid valve, severe pulmonary disease, presence of left ventricular thrombus or the presence of active endocarditis. Some of the relative contraindications also include a valve annulus of less than 18 and a valve annulus of more than 29 millimeter, or if your coronary height is low, or if there are mobile plaques in aorta and or the arch of aorta which may cause embolization, and unsuitable femoral artery anatomy. So some very important contraindications. Once again, if you do not have a heart team, you don't have a cardiac surgeon on site, do not proceed for a TAVI. The appropriateness of TAVI should be established by a heart team. Life expectancy has to be more than 1 year. If it's less than that, do not subject the patient to a TAVI. Your annulus size less than 18 or more than 29 are also contraindications. Active endocarditis, asymmetric calcifications, short coronary height, again as I discussed, are contraindications for a TAVI. So, as I said, STS score at 30 days is a very important predictive factor for post-operative complication rates, and should always be calculated in patients who are being subjected either to a transcatheter or a surgical AVR. Low STS risk is less than 4%, intermediate risk is 4 to 8%, high risk is 8 to 15%, very high risk is more than 15%. Now, coming to the types of the TAVI valves, we basically can use a number of valves. All of these can be used in almost all subgroups of patients. The three major valves are the Sapien 3 valve, the mechanically expanding Lotus valve, and the self-expanding Evolute and Evolute Pro core valves. Other valves, which include the MI valve, are also available. This is the first tower valve. This is one of the first tower valves. On the right, we can see that this is a Sapiens valve. On the left, we see a self-expanding core valve. So, if you see, on the top is basically a self-expanding core valve from Medtronic, also known as Evolute. On the top is basically the non-covered portion, which lies against the aorta and provides radial strength to the valve. The middle portion is basically providing us the circumferential force, and it hinges on the aortic valve calcification. And the bottommost portion, which the lower segment, which provides mainly the radial force, is anchored to the aortic annulus. And on the bottom, we can see this is a Sapiens valve, Sapiens XT valve, basically a balloon mounted valve, right? It's a balloon expandable valve. On the top is the core valve, which is basically a self-expanding valve. So, if we compare the two valves, the Sapiens valve is a balloon mounted valve, the core valve is basically a self-expanding valve. For a balloon expandable valve, we traditionally use larger sheaths, 24 French, and for the core valve we usually require 18 French sheath. LV apical approach is possible with a Sapiens valve. Implantation of a balloon expandable valve requires asystole, whereas the core valve does not require asystole. Partial retrieval is possible with a self-expanding valve. It's not possible with a balloon expandable valve, right? The main force for the balloon expandable valve is aortic elasticity, whereas in the core valve we also have the radial force from the upper and the lower segments. Ascending aortic support is present in a core valve. Coronary ostium anatomy is very important when you are using a core valve. It's not very important in a Sapiens valve. EV block, because the protrusion of a core valve is much more into the left ventricular outflow tract, is going to be higher. EV block is going to be higher with a core valve. Long-term outcomes of both of these valves are similar. So, initial valve was a Sapiens valve, then the Sapien XT valve, then we have the Sapien 3 and the Sapien 3 Ultra. Starting with 24 French, we have now moved on to approximately 16 French. If we see the core valves from Medtronic starting from 2009, and now we have the Evolute R and the Evolute Pro, requiring 6 to 7 millimeters of vascular excess. Several other valves also available in the market commercially, but most of the valves which have been commonly used are the Sapiens valve, the core valve, and in India predominantly large number of centers are using the MI valve. So, as I have shown, this is a MI valve made by Merrill in India. It is used at a large number of centers in India. Comes in sizes ranging from 20 to 30 millimeters, and it's again a balloon expandable valve. So, vascular excess can be from either the transfemoral, which is the most commonly used approach, then you can use a transapical approach, which requires a thoracotomy. We can use a transaortic approach, which will require a sternotomy, and sometimes we can also use the axillary subclavian or the carotid access, and sometimes when none of these are possible, we can use a transcaval access. Now, antithrombotic therapy is very important. After TAVI, we are usually going to go for a dual antiplatelet therapy, which will be later switched to a single antiplatelet therapy. But if the patient has an indication for a concurrent anticoagulation like atrial fibrillation, then we may have to put the patient on a triple antithrombotic therapy. I think I am going to skip a few of these slides. Just a basic point is that the choice and duration of antiplatelet is going to be tailor-made for every patient. It's not a fixed regimen. So, most of the patients are going to go on dual antiplatelet therapy. Triple is generally avoided because your bleeding rates are going to be much higher. When a patient does not require anticoagulation or DAPT, then just a single antiplatelet therapy would be okay. If anticoagulation is required, you are usually going to give a warfarin or an acetone to these patients. DAPT usually consists of 75 milligram of aspirin and 75 milligrams of clopidogrel. Now we'll basically discuss the data that supports TAVI over surgical AVR or TAVI over medical therapy. So the partner A trial was done in 699 patients, randomly assigned into two groups, TAVI versus the surgical AVR group in patients who are high risk, right? If we see that the all-cause mortality is 3.4% in TAVI group versus 6.5% in the surgical group, and secondary outcomes were 8.3% in the TAVI group and 4.3% in the surgical AVR group. So basically, in patients with severe AS who were high-risk surgical candidates, TAVI was found to be non-inferior to surgical AVR at 1 year, right? So this is in high-risk patients where TAVI is found to be non-inferior, and the all-cause mortality is similar to surgical AVR. Then we have the partner B trial in 358 patients randomly assigned to TAVI versus medical therapy. These are patients who are prohibitive surgical risk, they cannot undergo surgery. In these groups of patients, it was shown that the primary outcome was much, which was basically all-cause mortality, was much lower in the TAVI group as compared to medical therapy group. Conclusion was, in patients with severe AS and very high surgical risk, not suitable for surgical AVR, the primary endpoint is lower in the TAVI group as compared to medical therapy group, and hence TAVI was superior to medical therapy in these groups of patients. Then we have the partner 2 trial done in large number of patients, 2000 patients randomized either to TAVI or surgical AVR. These are basically intermediate risk patients. We see that the primary outcome, all-cause mortality or disabling stroke at 2 years, is equivalent in the two groups, 19% versus 21%. Also, the secondary outcomes are similar between the two groups. Life-threatening or disabling bleeding, as we can see, the secondary outcome is lower in the TAVI group as compared to the surgical group. So basically, TAVI is non-inferior to surgical AVR with respect to primary endpoint at 2 years in patients who are intermediate risk. Then we have the partner 3 trial, which was one of the latest trials, done also in a large number of patients, 1000 patients randomized to TAVI versus surgery. These are all low risk group patients. Here we can see that the primary outcome again is lower in the TAVI group as compared to surgical AVR group, and most of the secondary endpoints are also lower in the TAVI group. So patients with severe AS who are lower surgical risk, again your primary endpoints at 1 year is lower with TAVI as compared to that with surgery. So we've seen that in high risk, prohibitive surgical risk, intermediate risk, low risk, in most of the cases either TAVI is found to be non-inferior or it has been found to be superior to surgery. Again, the SIR-TAVI group in patients with intermediate surgical risk, it was found that TAVI was non-inferior to surgery. Again, this is the popular TAVI trial in patients who are receiving oral anticoagulation. Serious bleeding over a period of 1 year was lower with oral anticoagulation alone than with oral anticoagulation with clopidogrel in patients. Basically a trial of anticoagulation with or without clopidogrel after TAVI. So it was seen that you just give them anticoagulation rather you giving the anticoagulation plus antiplatelet. The study of U.N.M.I.C.R.C, basically a balloon expandable valve, 6-month study showed that there is a low risk of mortality, lower incidence of stroke, and lower requirement of permanent pacemaker insertion. Right, so U.N.M.I.C.R.C study basically showed the safety and efficacy of U.N.M.I.C.R.C transcatheter heart valve with no PPM requirement, no pacemaker requirement about 12 months of follow-up. This is basically study done at multiple centers in India. So if we see in patients who are prohibitive surgical risk, TAVI is superior to medical therapy. Also in high risk patients, TAVI is non-inferior or superior to surgical AVR. If we see in intermediate risk patients, TAVI is again non-inferior, and if we see in low risk patients, the partner 3 trial basically showed that TAVI is superior to surgical AVR. So for most groups of patients, we've seen that TAVI excels over surgical AVR. What favors TAVI is very elderly, few years of life expectancy, calcific valve, tricuspid valve, concurrent conditions, concurrent respiratory issue, lung issue, liver issue, severe lung, liver or renal disease, a lot of frailty. What is basically in favor of surgical AVR is a bicuspid aortic valve or rheumatic valve, associated diseases like coronary artery disease or mitral valve disease. So if we look at the guidelines, again this is a very congested chart. Basically it divides in patients with severe aortic stenosis if they are high surgical risk. So on the right side of the chart we can see if the patient is a very high surgical risk and the life expectancy is good, then these are patients who are going to go for TAVI. If the patient is not a very high surgical risk, Then we assess if the patient has any contraindications to anticoagulation. There is no contraindication to anticoagulation. Patient's age is less than 50, go for a mechanical surgical AVR. If the age is 50 to 65, either metallic valve or a bioprosthetic valve. If the age is more than 65, go for a bioprosthetic valve. Right? Again, if patient cannot tolerate oral anticoagulation, then you preferably have to go for transcatheter approach, because these groups of patients can be managed with dual antiplatelet therapy. Said this is a class 1 recommendation. So surgical AVR is preferred among patients less than 65 years of age and where the life expectancy is more than 20 years. So less than 65 years of age, generally advise these patients to undergo surgical AVR. These patients will receive a metallic valve. The life expectancy of a metallic valve and the durability of a metallic valve is much higher as compared to a bioprosthetic valve. And surgical AVR is preferred if a vascular anatomy is not feasible for a transfemoral TAVI. Is preferred among asymptomatic patients with class 2 indication for intervention, such as an abnormal exercise tolerance test or a very severe aortic stenosis. If feasible, transfemoral TAVI is preferred in patients more than 80 years of age and when your life expectancy is less than 10 years. Surgical AVR or transfemoral TAVI is recommended after a shared decision making, and the treatment needs to be individualized, and just the patient's biological age should not be taken into consideration, but it should be a shared decision making after a heart team approach, taking into account the patient's wishes as well. TAVI is preferred among symptomatic patients with a very high surgical risk or a prohibitive surgical risk if your life expectancy is more than 12 months, and if it's less than 12 months, these patients should be subjected to palliative care. Coming to role of TAVI in bicuspid aortic valve disease, preliminary studies excluded these patients because of the more oval shape of the annulus, eccentric, tiny calcification of the leaflets, presence of raphe, the higher chances of annular rupture, and most importantly higher chance of paravalvular regurgitation, need of permanent pacemaker, also associated aortopathy, dilated aortic roots which also require repair in the form of a Bentall surgery. So most of the preliminary studies excluded these patients, but now the outcomes in these patients are also similar to patients with a tricuspid degenerative aortic valve. But the consensus is that the younger patients with eccentrically calcified valve leaflets with bicuspid aortic valve, ascending valvular disease, preferably should be subjected to surgical AVR. Only elderly and very frail patients with comorbidities need to be subjected to a transcatheter approach. For aortic regurgitation, TAVI has mostly been used for calcific AS because you need a good amount of calcium to hold on to the valve. But newer generation balloon expandable and self-expanding valves also can be used for primary aortic valve regurgitation. A lot of data is still not available on the role of TAVR for primary aortic regurgitation, and we need to wait for more data before we can advocate the use of TAVR for primary aortic regurgitation. So mostly it's for sclerodegenerative or severe calcific degenerative aortic valve stenosis with a tricuspid aortic valve. Preferably should not be done in patients with the bicuspid aortic valve disease and in patients with primary aortic regurgitation. Very important is prior bioprosthetic aortic valve failure. So TAVR for the management of this is an alternative. Rather than subjecting these patients for a redo surgery, many of these patients can undergo also known as valve in valve. Right, so they can undergo, patient who has a bioprosthetic aortic valve done previously, now who is a very elderly, cannot undergo repeat surgery. These are subgroups of patients who are suitable for TAVR in a surgical bioprosthetic aortic valve. So TAVI in TAVI, we know the durability of TAVI usually reaches around 10 years. More and more experience is now available for placing a TAVR valve within a degenerated old valve or a degenerated surgically placed bioprosthetic valve or a degenerated TAVR valve. So previously done TAVI can also be subjected to a redo TAVI, also known as TAVI in TAVI. Again, this is going to be a procedure which will be frequently done in years because the life expectancy of patients is increasing, and the durability of the bioprosthetic valves we know usually does not exceed 10 years. So in future, TAVI in TAVI is going to be done more frequently, and we need to be aware of what this procedure is. Thank you.